Hello.
We have
Hello.
Hello.
Feelings?
we have no assembly members on the phone. We have folks from. Okay, there's the and that's Mr. Brown. And then we have Dr. Halligan is on the phone, and then two
I'm on
other,
the phone.
two other folks from.
Sorry, I'm on the call.
We hear you.
No, I'm an egg salad, had indeed had onions. So stay over.
All right. Why don't we go ahead and just dive in? I don't anticipate this work session will take the full hour. Welcome, everybody. This work session of the Anchorage Assembly today is August the 4th. It's 11:51 a.m. We're here to discuss AR 2023-221, a resolution of the Anchorage Assembly approving a portion of the issuance of Public Finance Authority revenue bonds, Series 2023, Aurora Integrated Oncology Foundation, in a maximum aggregate par amount not to exceed $250 million. Before we start, we'll do introductions. Please, Mr. Salt, since your mouth is full, you're first.
Karen Bronga. Anna Brawley.
Christopher Constant.
Randy Salt.
And invited on the phone, we have Mr. Johnson.
Yes, here.
Thank you. And Mr. Rivera.
Here.
Any other assembly members on the phone? Hearing none, we'll go around the room now. Ms. Hinshaw, just introduce yourself.
Hi, good morning. Sherry Hinshaw, CEO of the Aurora Integrated Oncology Foundation.
Good morning. Bill Popp, Chair of the Board of Directors of Aurora Integrated Oncology Foundation.
Thank you. We also have Dean Gates Assembly Counsel, Matthew Hurt, Legislative Counsel, and a few other folks in the room. So several months ago, Sherry reached out, Ms. Hinshaw reached out to me and asked if we would consider moving a public hearing and a resolution of support for the Aurora Integrated Oncology Foundation and their issuance of the revenue bonds. So it took a while for us to get this in the flow and before the body. We have this item before us on Tuesday. The requirement is that a public hearing is held and then the assembly adopts the resolution. And if that happens, then that demonstrates support for Aurora Integrated Oncology Foundation's effort to issue revenue bonds based on their operation. So I think what we'll do for this work session is allow Ms. Hinshaw and Mr. Popp to provide us with an introduction to the concept, what the foundation is doing, and why we're here, and then members can ask questions. So Ms. Hinshaw.
Sure. Good morning, and thank you so much for your time today. I also wanted to introduce Dr. John Halligan, who is based out of Anchorage, but he's traveling today. And so he is on the line. And I've also asked him to speak to the founding of the centers and his history providing oncology services in Alaska. So by way of introduction, Aurora Integrated Oncology Foundation is a new 501c3 that's really formed for the purposes of improving the care and access to care for oncology in Alaska. And we really appreciate the opportunity to speak to you all as a new organization, really looking to make significant improvements and growth in the way that care is received in Alaska for all oncology through the acquisition of these radiation centers and working long-term to really look at the sustainability of care in Alaska. So Bill is going to speak from the chair perspective, and then we'll turn it to Dr. John Halligan.
Thank you, Sherry, and Mr. Chair and members of the Assembly. Thank you for taking time out of your busy day to be here with us today to hear our story and to talk this through. I was approached late last summer, a year ago, to consider becoming a member of the board of directors of the newly formed Aurora Integrated Oncology Foundation. Fundamentally, what got my interest on this is that this will be the conversion of what are currently for-profit radiation therapy centers located in Juneau, Matsu, Anchorage, and the Kenai Peninsula and Soldotna into a nonprofit single entity. The value of this, from my perspective, in the initial representation of this to me, which I have definitely been very pleased to see how it's all coming together, is that we will take these 4 independent entities and create one integrated entity focused on delivering a higher level of radiation oncology services to all citizens of the state of Alaska and in the regions that they serve. And the charitable aspect of this is going to come in the form of charitable care. We have not fully formulated all of the direct structures related to that charitable care because we're still forming the organization. But conceptually, we have an overall focus on trying to better serve the native populations of the state of Alaska, which suffers from a much higher rate of several cancers that are treatable through radiation therapy. We are also going to be looking, of course, at charitable care for the general population. And as the organization matures and as more revenues become more available, we are going to be focused on also potentially providing funding for advanced training for nursing, for physicians, for radiation technicians. All of those kinds of things are on our slate to look at as we start to move this entity forward. Where we're at right now is that we've been going through a very intensive due diligence process of evaluating the 4 practices and their assets, their book of business. I chair the transaction committee, which is made up of the 3 current board members who are arm's length. We have absolutely no financial interest in this transaction whatsoever. We are 3 members of the community, including with myself is Michelle Brown, former director of United Way of Alaska, and Dr. Donna Gabriel, who is a physician with South Central Foundation, who are arm's length members who are the transaction committee. And our job is to understand the value of the transaction and making sure that we are properly representing it to potential bond purchasers, and to ultimately, the 3 of us approve the transaction going forward and going out to the bond market, which we are hoping to complete in September. With the transition to this structure, patient care will basically not see any changes. The structure will remain the same. Certain physicians and current owners of the 4 different practices will be cashed out in this process, but we do have a very clear structure that is designed to retain talent within the organizations through subordinate bond issuances to them for funds that they are going to be putting into reserves. This is designed ultimately, though, to provide us with a revenue stream that we can dedicate towards the charitable purposes. Now, I don't want to make it sound like it's going to be, 50% of what we generate is going to go into charitable purposes. The majority of the resources of the organization generated every year will go right back into the organization. It's going to be to upgrade technology to maintain the latest and greatest in radiation therapy technology. It will be focused on attracting and retaining the best talent that we can for the organization in all levels of staffing. And it will be focused on making sure that the organization remains sufficiently viable for a long-term future. But our ultimate goal is that a minimum 5% of overall revenues of this entity will go back into charitable purposes. We are hopeful that it will actually be more than that, but that will be down the road based on contact with reality. I want to note, as a former member of the Kenai Peninsula Borough Assembly, having had a couple of these kinds of transactions come across our agendas when I was on the assembly, then one of the key questions that I always would ask is, how does this transition affect our revenue streams? It will not. Property taxes will continue to be paid to the municipality of Anchorage. And if anything, if we are successful in growing the practice, it will actually provide an input to further economic development for the community, which of course I have near and dear to my heart. Was really excited about that particular aspect also. But it will provide an integrated network of services across the state The transaction is nearing completion. As you see in the documents, it's going to be about a $250 million bond issuance, which is not small potatoes. These are large practices. But we are very confident in the business model that we have developed, and this is something that's been done many times across the United States. And we are very appreciative of the Assembly helping us to deal with this requirement of the federal government to have this hearing and to get your tacit blessing of this transaction with absolutely no financial entanglements for the municipality of Anchorage whatsoever resulting from your approval of this resolution. So, Mr. Chair, I'll stop there.
So I have a couple questions, but I think you wanted to let the doctor speak first. So why don't we do that?
Okay, good morning, everybody. John Halpin, actually talking to you from the back of Mount Johnson's house in McCarthy. Here was one of the few places I can have be quiet here and cell phone coverage. But as some of you may have known, I came up to lab 15 years ago at Providence, and that's still where one of our main offices is, and saw lots of people from across the state who are having to travel for long distances and be away from their family to receive radiation therapy care. And after doing it for roughly 5 years, we opened our first center in Soldotna, coordinating and working closely with the hospital down there at Central Peninsula Hospital. A short time later, we opened a center in Juneau to help ensure that people from Southeast Alaska, in Alaska, can get their care. And then we opened our center in the Texas Valley to improve the quality of care that's going on out there. They had simply older equipment that was no longer state of the art and actually have stayed in quite a long time. And finally, we opened the Review County Cancer Center to establish a freestanding center outside the hospital. We took over a practice that was failing after the urology group which had started that, and that opportunity had gone away. But as I've been here and looking to what we've done, we've brought the state-of-the-art cancer care to Alaska and for remote parts of it. We continue to upgrade our technology. And as I start to look on the horizon as a 60-year-old guy now and looking how we can continue this, there were several options of what to do with practices, and one of my main driving forces for this transaction was I wanted to ensure that the centers that we built and the state-of-the-art equipment and the ability to deliver state-of-the-art care in Alaska remains long after I'm gone. And in discussing different ways of doing that, we found that the foundation would likely be the best way of ensuring that cancer care and maintaining the state-of-the-art would be the best way of doing that, rather than selling to, say, another chain or selling to a hospital, but really to create something that their function is to ensure and technologically state-of-the-art care continues in Alaska. And as part of that, also having a charitable portion, one of the things that has been nice for some of our centers is the ability to take care of uninsured people, to help people with transportation needs, to help cancer patients get the things they need. I started a fund at Providence probably 12 years ago, doing a similar thing for our Providence patients, because coming out of the military like I did, my patients had everything they needed, whereas I found when I transitioned to private practice, simple things that sometimes patients needed weren't available, and they didn't have the funds. They were essentially the working poor were the ones that did not get what they needed. And so we started a fund that I did at Providence just to take care of those patients and provide those services. And I see a big part of the charitable aspect of this organization going forward helping take care of cancer patients, and as additional funds become available, doing things like helping develop local talent in, nursing, and as Bill may have said, radiation therapists, training people from Alaska, and possibly scholarships and things that charitable organizations may do to ensure that we continue to have a vibrant and state-of-the-art cancer program that's really directed to help our patients. So I will stop there. If people have any questions, I'm certainly happy to help answer also.
Does anyone have questions? I have a couple. Okay, you go ahead, Mr. Salt.
Thank you, Mr. Chair. So I haven't seen arrangements like this before, so you probably explain why the municipality is getting involved, what appears to be like private financing. So I read some of these statements, and I apologize, I go to a dark place. So what I read is as a nonprofit, which is owned, I don't know if it's owned by a profit, I'm just kind of reading this here, but it looks like you're going to buy the 188 West Northern Lights Boulevard location from Anchorage Midtown Radiation Oncology Center, which I'm pretty sure is probably a leased facility. And then you're going to purchase the practice at Piper Street, which is, my guess, also a leased facility. So you're not buying a physical building or anything like that. You're probably buying the assets with inside. But I just worry why wouldn't you follow conventional financing? And my concern is like, this is just a cash out for the two companies setting up a nonprofit to use bonds, lower financing the cash out. And then how do you control salaries with the nonprofit? And kind of like a movie, it never produces a profit because the salaries take that up. So just kind of my dark places. And if you could answer some of that, I'd appreciate it.
I'll take a first shot at that because those were some of the things that I asked at the beginning of this. So there's a management company by the name of RBS that will be part of this transaction and will be obligated to be part of this. They are a professional management company that ultimately manages all of the aspects of the organization on behalf of the nonprofit. The board of directors is responsible for reviewing and approving the annual budget. We are responsible for setting salaries for the physicians. With the advice, the professional advice from RBS. Our goals are to, of course, maintain proper cost controls, but also in the same hand, looking for those opportunities to reinvest in the organization, as well as to maintain the integrity and growth of the charitable side of the entity also. One of the advantages that we will have as a 501c3 is that we will eliminate the federal tax component of this, which will create more revenues available for the organization. That yes, there are individuals who have a vested interest in this transaction that are selling their interests and getting cashed out. This has happened in multiple organizations across the country. And these are aging physicians, and this is bringing surety to maintaining these practices, as opposed to the potential of having the practices ultimately closed out as part of the process of closing their book of business, or the perhaps less successful model of selling to a national entity who may not put the resources into the entity based on certain profit motives. It's taking quite a bit of the profit motive out of this particular line of business. So I don't know that that's a clear picture for you on this, but yeah, there is a combination of meeting the individual needs of some of the current owners. Many of the owners are remaining with the practice in the new piece and have a financial obligation to remain because of the subordinate shares, subordinate bonds that are going to be issued to them in the structure. But it's all about, I believe, converting this to a different model with a different motive, which is a higher level of thinking for the physicians that are going to still remain involved in the practice.
Yeah, and Bill, let me take a stab at that also. This plain I think you hit the nail on the head very well. One of the problems that I have seen during my career and seeing different practices in radiation oncology, talking to colleagues, the profit motive in once the technology is there, basically not reinvesting and not maintaining things as the quote unquote state of the art but continuing to, use each piece of equipment until it absolutely is no longer viable, as opposed to maintaining the state-of-the-art equipment that I believe the foundation would do. And my big part of my goal, and I'm one of the best people, I could make more money, I believe, if we went and sold this to a fifth-dimensional cancer scene or another healthcare entity. I think we actually make more, but that would take away some of that control that I see the foundation providing to ensure that Alaskans always have the state-of-the-art care. And that's a big difference in how we're doing it. And I think one of the things we have set it up is that those of us who are physicians and owners, and my intent to practice for at least 4 more years, and my other partners, I think, longer. But as we set it up, some of our payments that we would get are dependent on the success of the foundation going forward. But we have established a way that the way that funding is, I think, the mission of the foundation and delivering the state-of-the-art care, maintaining the technical expertise, takes precedence over that subordinate debt that Phil was talking about. And to me, that's a benefit for the foundation and the community rather than us as physicians or owners of the centers.
Sure.
This is Julie Seymour from Nixon Peabody. I'm representing the foundation in connection with the acquisition and the bond financing. And I just wanted to also add to what Bill and John had to say in that the IRS rules around the not-for-profit tax-exempt entity require us to obtain validation of the price that is being paid to acquire the physician practices. And in addition, we've also obtained valuation with respect to the amount that the physicians will be paid going forward as employees. And so there are third-party companies that are looking at the valuations to ensure that there is not an overpayment for the practices and that the physicians are being paid no more than the fair market value for their services going forward. Just wanted to respond to the question that you asked about the, taking all the money out of it and not having enough money left to further the purposes, the charitable purposes of the organization. That is something that we're paying very close attention to make sure that is in fact the case.
I would also note, if I could, just as chair of the transaction committee, that there are some really strict covenants that we have with the bondholders for maintaining appropriate cash on hand, maintaining appropriate third-party validation of expenditures on both staff as well as new equipment purchases and reinvestments. And it's a pretty aggressive model that makes sure that we maintain the focus on the delivery of services at a cost-effective price.
Can I ask one more?
Sure.
This doesn't take effect the municipality's bond rating or bonding capacity.
No, sir. None whatsoever.
All right, thanks. I have actually 3 questions. You mentioned that the board, the small board that is oversight, doesn't have financial interest. So you're not a paid board. And he nodded yes. Mr. Pop nodded yes. And but one of them is a doctor. And is the doctor in the cancer field?
The doctor represents some of the physicians of the practice on the board, and the physician does not get to vote on anything that has to do with direct opportunities for remuneration, et cetera.
Compensation. Okay, thanks.
There is an arm's length element in this, And I would mention also, we are now entering into the next phase of discussions of board expansion.
Right.
And we're going to be looking for regional representation as well as talent representation. And that will add to the number of arm's length members who do not have a direct financial interest in the organization's day-to-day profit and loss.
So the next question is the property tax question. You suggested that this would not take properties off the tax roll. As Mr. Salt suggested, these look like leases. And so if at some point in the future, the foundation opts to buy property, would those properties be somehow subject to the tax roll, or would they be excluded under the 501c3 tax exemption?
I believe that where we're at right now is that we have properties down in Juneau that we are going to be purchasing, a facility as well as a guest house in Juneau. And those are going to remain on the tax rolls. And I believe we are going to maintain that covenant if in the future. I can't speak, of course, for future boards, but at least at this point in time, I believe that we would continue to maintain that covenant.
Okay, and that's kind of payment in lieu of taxes or just actual taxes. It's an interesting question. So the final question I have is, okay, so this organization is going to consolidate four for-profit entities. Currently, those for-profit entities, although geographically disparate, in some ways compete with each other. And so what comes to mind is what happens in a town when you only get one healthcare provider. Does that healthcare provider get unchained in the context of pricing for services? And does this create an anti-competitive cycle in our healthcare industry, and especially as it relates to oncology?
I'm going to take a shot at it, and then I have a feeling others are going to take a shot at this too. But I would say, no, it doesn't, because there are still several practices out there that are still independent. We are technically in the market perspective going to be competing with them for services. We are also very much governed by the prevailing prices that insurers are going to be willing to pay, as well as Medicaid and Medicare providers are going to be willing to pay. And those are all, definitely keeping us honest and forthright. The practices also provide different, focuses in areas of practice. Like, for example, currently right now, the Matsu facility focuses quite a bit on prostate cancer. That's kind of their specialty. We haven't had a conversation yet about, is there going to be a change in services on that? But the one thing that we will be able to do is to be able to continue to provide opportunities for referral where needed to other facilities within our network. And then if we have a need for charitable help in terms of travel, that's something, of course, dependent on available budget, but that is something that we would also potentially be able to provide to a patient in that area. So we're looking at this as also as an opportunity to integrate different practices with different specialties and being able to expand those specialties and the delivery of them to elsewhere in the state and to citizens from other parts of the state.
Sure.
Bill, I also want to add a comment on this. So within consolidating our practices, really, which are across the state into a single entity, the competitive aspect is really within Anchorage and the Matsu Valley. There already are centers that are going to remain independent. There's a freestanding radiation oncology facility at Alaska Regional Hospital that is not owned by a hospital. It's similar to ours. It's actually owned primarily by 3 physicians who are no longer in Alaska. So we are always in a competitive environment technologically and quality of care wise with those. And the same thing goes with the Matsu Valley. There is a center that is owned by the same group that owns the Alaska Regional group. And, when we opened our center out there, that forced them to upgrade their accelerator, which, as I previously mentioned, was really vital. We really we continue to upgrade our stuff, bringing up technology, something called Vision RT, which is a really impressive new technology for aligning patients and doing certain types of higher level radiation oncology treatments. So I think the competitive nature is still going to be there. There will be certainly benefits in management and consolidating contracts for services like physics and dosimetry support, which will bring efficiencies of a larger entity and allow some savings there, which again should contribute to the long-term financial viability of the charitable aspects of the foundation like we're talking about. And in addition, as many in Alaska are aware, you know, the cost of healthcare is high, and these consolidations will possibly allow us to lower costs further over time. And also, if there is any significant change in reimbursement for these centers to become more efficient and tolerate and survive, if there is a drastic cut in reimbursement in Alaska.
Sure, and just to add some of the benefits of thinking about the centers now, they do have some shared services and they do collaborate now. What the benefits of some synergies to be gained is in the future being one entity, for example, is when we're purchasing a new linear accelerator, we could purchase 5 and, you know, have it spaced out over years and get a much better price, and are really already engaging in some of those conversations that will end up saving millions in terms of purchasing that new technology. And then finding ways then to share electronic medical records to bring other synergies into these centers that are already collaborating on care, but even bring it more together. So there's some integrated care services that are offered in Anchorage that could be offered at other locations: naturopath, massage, palliative care. So really looking at adding, you know, taking those staff and being able to share them out more to bring services that an individual freestanding clinic in a small location would otherwise not be able to access. And then I wanted to just clarify too, the physician on the board in independent practice, the independent board member, she's the chief medical officer of South Central Foundation, Dr. Donna Galbraith. So she is a primary care provider, and I think is an incredible leader on the board with an interest in addressing some of the health disparities of the really late stage diagnosis in Alaska Native populations and in Alaska generally. So looking at how do we, there's the data shows us that there's a high number of Alaskans who do not access care until it's very late in diagnosis. So part of the work of this is to not only bring enhanced services to cancer patients now, but how do we start to create access to earlier screening and earlier treatment that can have a better outcome? So that's some of the work that the board has been focused on and that we'll get to do past this transaction.
So before I hand the mic over to Ms. Brawley, that raises like the previous comment that it's not anti-competitive because it provides all of these synergies and et cetera. It's a fair argument. There's an opposite argument to that, and that is your competitors you mentioned one, and we don't need to name anyone else, but should we anticipate on Tuesday that we're going to hear from folks opposing this proposal? Have you had that across the state anywhere? You know, when somebody proposes to open an imaging center, the certificate of need argument comes up, and then Providence is there saying, don't let them do this, because Providence is pretty good at that business. And so are we expecting that, and how would you suggest we deal with that should it come up?
So this was determined to not need a certificate of need. I think that's a good distinction too. And this same process happened in Kenai without any hiccups. It especially is a welcome because it brings more long-term sustainability. So, and I think Bill can add more, but or Julie even, on how TEFRA hearings have gone in other locations. It's somewhat of an older rule for projects like adding a public jail that you might see more public input when it's a really contentious project. What we've heard so far is that this is really a welcome project in that we're coming together to take for-profit practices to nonprofit to really serve a long-term charitable purpose, which is slightly different.
If I could also, just to mention, as an example, Providence is basically a partner with the Anchorage practices. And the practices that are going to become part of Aurora Integrated Oncology are already providing the radiation services that Providence cannot provide. And we have quite a bit of work that's ongoing, generated on Providence referrals. And Providence is so far been, to the best of my knowledge, very, supportive of what we're doing.
All right. So you brought up Providence, and that was kind of part of my thinking. And I don't mean to talk badly about them. I think they're a great partner in the community. But there has long been a history of Alaskans being charged extraordinary sums through a nonprofit hospital that underwrites services in the whole Northwest of the United States, where service is actually cheaper. And so we find ourselves through a nonprofit paying more so that other people can have cheaper care. It's an interesting dilemma. You don't need to answer that. That's like a,
Well, I would like to make one comment.
okay.
I would note that you're going to have a locally based board of directors here in Alaska whose neighbors are making use of these facilities, and we are going to be vigilant for especially the arm's length members, which we're again trying to grow the size of that. We are going to grow the size of that. That represents all of the different constituencies that we represent. And I have a sneaking suspicion if we start getting wind of the fact that prices are turning into the gouge range of pricing, we're going to have some internal conversations that are definitely going to push back on that.
Yeah, because that is an ongoing concern for healthcare in Alaska. Ms. Brawley.
Yeah, thank you. That's a good transition, because the questions that came to mind for me were more system related. So I also want to acknowledge you guys are basically one provider or one set of providers. And so these questions aren't all related to you or the tenure. But I think to the point about healthcare, I mean, certainly Alaska needs to reform our healthcare system, and we need to decide to do that. And that is not on the back of one individual provider. But I know Ms. Hinshaw and I have both had prior lives where we were involved in that. So I look forward to that conversation continuing at the state level. So I had three questions. One, or the first two are related, I guess. And I appreciate Dr. Halligan's mention of the working poor and the acknowledgement that, people need care, and the system that we have is that you have to pay for it or someone pays for it directly. And I suppose that's true in every healthcare system. One is, do you guys accept Medicaid and Medicare? And then also you mentioned service to rural Alaska and the disproportionate cancer rates there in particular. So I'm just wondering, beyond having a member of or a employee of South Central Foundation on your board, how do you interact with the tribal health system?
I can speak to a couple. So yes, short answer, yes, in terms of accepting Medicaid and Medicare. The board of directors has adopted charity care policies that really are, we will serve. It's a longer policy, but we will serve regardless of ability to pay, and which is not the centers have already been serving Medicaid and Medicare populations, and so I think that will continue and grow as we create more access to care, ideally. In terms of the tribal health system, that is one of the system goals, policy, or advocacy work of the foundation that I'm personally really excited about, is how can we bring together and really think about care differently. So value-based care is something that is much more evolved in other states. How might we do different value-based care within the oncology, not just radiation oncology, but within oncology in Alaska? And one of the exciting parts of bringing so many people together with the board leadership and strengthening connections with tribal health is how can we look at that more holistically, not just from one provider. So whether that's a charitable initiative of the foundation in terms of the actual grant making or not will be a board decision, but I think that is an opportunity in front of us.
And then my other question, or I guess this is maybe in the category of comment and a question, is you mentioned charity care, and I appreciate the focus on increasing access to this care, the training. I think all of those pieces are really looking at gaps in our system, or at least, stress points in our system. But I guess I would also say, or wonder if you guys had discussions about focusing specifically your investments on prevention. So, certainly the way that we reduce cancer care rates is not through treatment, although we do need to recognize treatment. There's a continuum, but it's really focusing on upstream prevention. And so, not saying that thinking that you guys as an individual provider are standing up programs, but I wonder if that's been part of the discussion or, a portion of set aside that goes to prevention programs. I know we have a comprehensive cancer prevention plan. And then also I just want to flag if there's been discussions about patient housing. So and I guess I'm curious too, you mentioned there's a guest house in Juneau, and I know in Anchorage, one of the big things we see is folks, fly in from other places and get care and then do not have a way to get home or just don't have the housing resources for their recovery. And in fact, we've been standing up programs such as at Brother Francis to help with medical respite, not for things like, long-term treatment. But anyway, just curious to your thoughts about this Charity Care's investments in prevention and patient housing.
Sure.
Sherry, this is Greg Merrill, as the management company representative. Would you like me to take a response at that?
Sure, Greg, and maybe I'll just add one comment, and then you can add to it. Does that work? So those are such great points in terms of how do we collaborate on all of the partners working on this work and not recreate. And so I think we have some great networks in Alaska that are working on prevention. And so how do we help increase their capacity and resources and work together? I've been so impressed with this group in terms of the top tier talent and technology that they've brought to Alaska. And so keeping Dr. Halligan, I'm planting the seed already with him staying on long term because he has an incredible background and has been able to recruit providers to this state from the best universities in the U.S. And so I think how do we both work on prevention and early intervention, but as well as access to current treatment now? I think that's something that is cancer is one of the leading causes of death in Alaska. So we have some outcomes that we really do need as a state to work on, not just one provider, but across partners. So really looking at some of the early conversations with the board is where should we invest our philanthropic giving to make an impact on all of those areas you mentioned. They haven't formalized those policies yet, but I do know that prevention and early intervention is a consideration there. Just to add to, I think this is some of the future work of the foundation once we're stood up, is to really fully add additional board members to really look at giving priorities and then how we can help contribute to the health of Alaskans with our piece of it.
And if I could, before Greg jumps in, I just want to nuance that. We're right now trying to get to the transaction and getting it successfully completed. The board really wants to focus on those very kinds of questions, but we've had so much work in terms of trying to get this transaction over the finish line that we just really haven't had that moment in time where we could sit down and, other than just to kind of in an offhand way, start to share ideas. The hard work's going to really begin after we get the transaction done.
We did have some initial conversations with the hospital in Kenai, and one of the reasons they were so supportive of this project is by having nonprofit status, it gives them room to work with us in a different way. So even working with their foundation to do patient housing together was an idea. So I think transitioning from a for-profit status to a nonprofit status opens up the world of partners that we can do collaborative projects like that with.
Yeah, and just to pick up a little bit on what was said, in terms of some patient housing, we do have a patient house in Southeast Alaska located in Juneau, and that will be part of the foundation. And that, as you can imagine, provides a wonderful resource to folks that are traveling in that area for access to oncology care. We also have a house in Soldotna on the Kenai Peninsula there. That is also for use for patients that travel across the Kenai. So Those are two elements. And then as a management company for the foundation, we've had the pleasure of being in Alaska for over 10 years, but then also having working with other cancer programs across the country, we have a lot of exposure to a lot of innovative population health programs that directly address those ideas around prevention, early detection, cancer awareness, and education. So those pillars are things that we fully intend to bring out of the foundation, and as Sherry said, align with partners throughout the state to accomplish that. We really view that as a wonderful opportunity that can touch a lot of people in the whole oncology experience. And we believe we can do that so much more successfully through the foundation. So we could follow up on that at another day. But just some responses to your point about prevention.
And then I would also add in, she mentioned, people having difficulty with transportation and things like that, which is something we've dealt with since I've been up here. The American Cancer Society does a great job, and especially before COVID, helped us out in a lot of ways. We're very big supporters of the American Cancer Society, but their volunteer ride program pretty much evaporated during COVID, and is not really been something I think that's been reestablished strongly yet. But we have done things like buying taxi vouchers for Uber and Lyft rides for patients. And that is something, I know getting people to and from appointments, especially in some of our more rural places, is a challenge. And I think the foundation coming up and having a uniform aspect and ability to do that across all of our centers, Juneau, Soldat, and the Manitou, and Anchorage, will help us help more patients. And that is certainly part of our goal with this foundation.
Yeah, thanks. And I appreciate that. And just to say too, I totally recognize that you guys have a lot of work ahead of you and you have to get through this phase. So I appreciate that you're thinking ahead and that you're on the same page, I suppose, as far as system changes for the better. Thank you.
We are extremely excited about the future once we get to it.
We don't just get to it, we build it. Ms. Bronga.
So I was looking at RBS. I didn't know what management company that was, but I found it and see this article in 2013 that celebrates opening a clinic in Soldotna and one to come in December in Juneau. So RBS was managing these two clinics that you're going to put under this blanket of this corporation now, this nonprofit?
Yes. Yes, and it's going to provide management services. It's been doing it under contract with those two entities, and it will provide significant continuity in terms of services and staff benefits and HR and all of those kinds of things. It's a fairly comprehensive management organization. So yes, they will handle all four of the practices.
And they had been prior to that.
Yes.
And it's just going to continue. So then the next thing is, I think I wrote down five.
They were actually doing two of them. Yeah, they were doing Midtown, Soldotna, and Juneau, but our Matsu Center is under a different management company.
Okay, thanks. The other thing I wrote down that you said 5% would be nonprofit. And then
Charitable.
in that same
Charitable.
So in that same grain, I heard you mention Alaska Natives as that population that higher rate of cancer, possibly that's the charitable piece. But they have what they call at ANMC a state-of-the-art oncology center, and many of the Alaska Natives are under Indian Health Service. I'm not sure that maybe it's needed because some of the Alaska Natives don't qualify for Indian Health Service. And then will you accept Indian Health Service if they do have that?
Sure. So some of the work involves understanding whether it's a lack of access to screening or whether it's more stigma around, there is some stigma around cancer care, around the treatment being worse than the disease, or individuals in Alaska have declined services because they're during subsistence season, and they're choosing to provide for their family. So it's going to be a multi-part process to really understand what is it that's contributing to those higher prevalence and later stage diagnosis, and then working with tribal partners, whether it's you have to have a certain amount of population to open a center. So it wouldn't be feasible to open centers in very small locations. So then it's looking at how do you reach into those communities for screening, for education, to address some of the stigma around accessing care, or misperceptions. Maybe stigma isn't the right word around accessing care. And that would be a partnership. So absolutely, the centers would serve individuals, any individual who needed care in Alaska, and the care was appropriate for them. But the work of the foundation from an advocacy perspective would be focused more on reaching into communities, whether they received care at these particular centers or not. The goal would really to improve all of oncology care in Alaska. And in terms of the charitable giving, the entire organization has a charitable purpose delivered through the care. And then there will be additional grant-making charitable giving that the board will determine the priorities on that as related to the organization's purpose, which again is around access and quality to oncology care. So I just wanted to clarify that.
I'd also offer, and the other part of your question is the fact that there is a not insubstantial number of members of the Alaska Native community who have private insurance through their employment and make use of private care. And those patients are already coming to the 4 different clinics, making use of their care. I do not know the answer in terms of Bureau of Indian Affairs funding coming through, as far as to our 4 clinics. I don't know that that's the case. I would leave that to the folks online.
I can answer that. So at our centers in Juneau and Soldotna, we have already taken care of quite a few patients from the Native Hospital. At Providence, we take care of 4. There is a contract between Alaska Native Hospital and the Radiation Oncology Center at Alaska Regional, that the patients who come to Anchorage and need radiation are being treated over there, but some actually do decide they want to be treated by us, and we certainly take, Indian Health Services or Medicare or Medicaid, whatever they're on, for private insurance. And we would hope that with Foundation, we could actually build even stronger ties with the Native Hospital and the other entities such as search to ensure that care is available to these folks, and have that they have more options, that if they choose to, it's easier for them to go to one of our centers closer to their home rather than necessarily staying in Anchorage for between 4 and 8 weeks for them.
Thanks.
Yeah, I think you said it really well there, Doctor, that it's like Medicaid or it's a funding source, and the funding sources are portable as long as the provider is opted in and screened to be a legitimate provider. And so it doesn't matter. Alaska Native people have some flexibility where they go for care. It's, again, just a funding source. So we're about out of time. We have about 5 minutes left. Do any other members have questions before Mr. Salt?
Yeah, just real quick. I'd appreciate if you could send me some information on the Aurora Integrated Oncology Foundation, because I can't find a website or anything like that if you have one. So
Haven't gone live yet
on
the website yet. We're not at that point. Once we get the transaction done, there's going to be a whole. We haven't gone quite live yet with that because we haven't completed the transaction. Once we complete the transaction and we're fully funded, you're going to see a blizzard of online opportunities to learn about us.
Okay, thank you.
All right, then why don't we allow Sherry, you, if you want to provide a closing comment, you have a couple minutes.
Mr. Chair, I'll go ahead and take
Okay.
that. We just deeply appreciate the consideration of the Assembly for this federal requirement for this TEFRA resolution. It's an important component. I will be actually, after I'm done with this meeting and done with cleaning up a last minute thing at the Anchorage Chamber of Commerce Board meeting, I am driving to the Valley to meet with the borough manager of the Matanuska-Susitna Borough to meet with them to talk about a TEFRA resolution out there. And it's our understanding that the resolution from Juneau will be taking place towards the end of August as far as their hearing. With all four in place, we do look confidently towards a successful bond offering in September. And we deeply appreciate the Anchorage Assembly's consideration of this required technical resolution that helps us out immensely in getting this over the finish line.
So I would just note that we have AR 2023-221 set for public hearing at our meeting Tuesday night. And we'll see what the public has to say, and we'll have our deliberations after. So thank you, everybody. We'll adjourn this work session.
Thank you.